Thank you so much for joining us in this next installment of the APDA Take Control series. My name is Jennifer Gillick, and I am the program director here at APDA Northwest. I'm very excited to present this program on palliative care and Parkinson's disease. I was first introduced to the concept of palliative care at a conference a couple years ago. And palliative care has been around a long time, but mainly has been used in regards to cancer treatment, as it really focuses on quality of life for someone with a chronic illness. And it's now kind of gaining some traction in the treatment of Parkinson's disease and really is an emerging field. And we have a wonderful panel of presenters here today to talk about it. Before we begin, I would like to thank today's sponsors, Kiowa Kirin and Synovian. Thank you both for valuing these educational programs. We certainly could not do this type of work without you. For those of you who do not know, APDA is the largest grassroots network dedicated to providing programs and services to the Parkinson's community. Increasing the public's awareness and knowledge of Parkinson's disease as a major health crisis, and invests in research to find effective treatments and ultimately a cure for this disease. And lastly, before I introduce our panel of speakers, I would like to invite you to participate in our Every 9 Minutes fundraising campaign. On average, every 9 minutes, someone is diagnosed with Parkinson's disease. And as you all on this webinar are intimately aware, the diagnosis doesn't just affect the individual who is diagnosed, but also impacts family members, particularly care partners. This year, we at APDA Northwest are really trying to increase our focus on providing programs and support specifically designed for care partners. So this fundraising campaign, which will run for 9 days in October, will help raise funds to support those programs. I will include information about this campaign in your post-event email, and if you can participate, we would really love that participation. And now, enough for me. We have a terrific panel of presenters from Swedish Palliative Care Institute located in Seattle. So they are here to share their knowledge, take your questions about palliative care. So I would like to welcome to the screen Dr. Christopher Flynn, who is a board certified palliative care physician. Hello, Dr. Flynn. And Reverend Lorraine Leist, who is a board certified chaplain. And lastly, but not least, is Joan Lester, who is a clinical social worker. Thank you to the three of you very much for being here and sharing this very valuable information.
Okay, so welcome everyone. And first off, I'd like to thank Jen and the rest of APDA Northwest for inviting us today to talk about palliative care, especially in the light of persons with Parkinson's disease. Just to give an overview, we're basically going to go into kind of what palliative care is and people that may not be very familiar with it. Then maybe differentiate between what palliative care and hospice, the similarities or differences. Kind of talk about the composition of our team, the common palliative care team, whether it be on the inpatient, outpatient, community-based sides of things. Kind of each of our roles and how we help persons and families dealing with Parkinson's disease. And then eventually to kind of tie it all together in the bigger picture of how we help persons and families dealing with this disease. Next slide, Lorraine. There you go. That's a slide. Thanks, Lauren. So, the definition of palliative care is specialized medical care for people living with a serious illness. That could be an acute, new disease or something they've been dealing with for years, much like Parkinson's disease, persons with cancer, congestive heart failure, emphysema, COPD, persons with kidney disease, either chronic or end stage on dialysis, persons with stroke, persons and families dealing with dementia, ALS, and just so many more. And the focus of our care is providing relief from the symptoms and stress related to the illness. And our ultimate goal when we get involved with patients and families is to improve their quality of life as they go through this illness. And as we know, each person, each family is individual. So a lot of our care and a lot of our assistance is really based on what their needs are. And, our involvement is at any stage in a serious illness. And it can be provided alongside curative treatment, meaning we get involved with cancer patients that are still undergoing chemotherapy, kidney disease patients that are still on hemodialysis. It doesn't mean they need to stop the curative treatment to already be involved with us and hopefully get some assistance from our extra layer of care. And I did want to differentiate kind of palliative care versus hospice. So a lot of times we get people kind of lump us all together, think that we're only, we're part of hospice, or it's mainly end of life care. Like I was saying before, our involvement is at any point in a person's illness. It's from the diagnosis all through possibly the end of life. A lot of my early involvement when I was in my fellowship with patients that just got diagnosed with cancer and they hadn't even seen the oncologist yet, but I was seeing them help support them through this diagnosis, helping with complex symptoms, so try to get them feeling better, improve their quality of life as they begin their journey. And like I was saying earlier, it can be provided alongside active life-prolonging treatment. A lot of what we do is pain and symptom management. That's a lot of my role on the team, as well as psychosocial and spiritual support. That's a lot where my team members, Lorraine and Joan, come in. And a lot of advanced care planning, meaning designating a person that may be the durable power of attorney for healthcare in case they become incapacitated and can't speak for themselves, as well as talking about kind of what's important to them should their illness progress and they get sicker. Hospice itself is a Medicare benefit. In order to qualify for hospice, you must have a qualifying diagnosis, the life expectancy of 6 months or less. And unlike palliative care, they must not be undergoing active treatment, meaning you can't still be on hemodialysis. If it's a cancer patient, they still cannot be getting chemotherapy or immunotherapy. But the similarity between palliative care and hospice is we do a lot of pain and symptom management, a lot of that psychosocial and spiritual support. And for hospice, it's more of that as people get closer to the end, that end of life care for the patient and the loved ones around them. And the big part of hospice that a lot of people don't know about is the bereavement support they have, meaning after a person passes away from whatever their illness is, their loved ones will have access to bereavement counseling for over a year after they pass away. And this is kind of a graphic representation of kind of what we're talking about kind of similarities and the difference between palliative care and hospice. Palliative care, hospice is kind of within the overall sphere of palliative care, meaning the support in the many different ways for patients when they go through it. The hospice is that little piece as they may be nearing the end of their life and they really need an intensive support and care, wherever they may be, whether it be at home, whether it be in a nursing home, adult family home, etc. Now, in palliative care, we take the team approach to caring for persons and their families. We recognize that it's not just a patient with a diagnosis, but there's a person with a whole life outside the hospital. And it's not just, physical things that may be going through due to this diagnosis, but it's everything that kind of makes us human, everything we need as we go through difficult times. The team itself is a provider like myself, either a physician, a nurse practitioner, a physician assistant, and in some places it's actually an RN who are working at the top of their license and are experienced in palliative care. A lot of what I do is pain and symptom management. I have a lot of discussions with patients and their families about what their goals of care are, kind of where are they in their illness, what's important to them, what are they looking forward to, what's acceptable or not acceptable as they go through this, and a lot of advanced care planning with them. Just kind of who their surrogate decision maker would be, as well as kind of what they're willing to go through, what they want to go through, and what would be too much for them. There's a social worker like Joan on our team here, who does a lot of psychosocial support as well as a lot of advanced care planning piece of things. And then we have spiritual care advisors, chaplains like Lorraine. They do a lot of spiritual and emotional support with these patients and families. As far as the setting of palliative care, for us, we're here on the inpatient side at Swedish First Hill. We also have an outpatient clinic here as well as many other cities. And in some places, there are community-based palliative care programs that may be able to go see people in nursing homes, see them in their home, adult family home, wherever they may be outside of the hospital or kind of clinic setting. As far as my role, like I said, I do a lot of pain and symptom management with patients, even patients with Parkinson's disease. A lot of the common symptoms we see are, kind of nausea and vomiting, fatigue, constipation, possibly diarrhea, sleep disturbances like insomnia, just really poor appetite and anorexia. And a lot of the goals of care discussions that I have with patients and family, where I help facilitate, these discussions that, about their illness and what decisions they may be facing in the future regarding their care. And some of those things may be initiating dialysis, undergoing chemotherapy if it's a cancer patient. If they may be older and have gone through a lot, whether or not they're willing to go through a big surgery. If they have respiratory issues, is having a tracheostomy tube and a mechanical ventilation, meaning being on a ventilator, is that acceptable to their quality of life? Or possibly things like permanent feeding tubes. But all these discussions are in the context of who they are, what's important to them, and what quality of life means to each person.
Hi, good morning, everyone. So I'm going to talk a little bit about what the social work role is on a palliative care team. And because our specific team that's talking to you today is specifically inpatient in the hospital, that's kind of how I'm focused, but I just want you to keep in mind that as Dr. Flynn said, palliative care can be provided in an outpatient setting. There's outpatient palliative care clinics, Swedish has one, and there's also community-based outpatient palliative care services that actually will send the clinicians into a patient's home. So I want to start out with one of the things a social worker does, and I feel like is one of my main roles, is to really provide a landscape of the patient's life. And by that, I mean, what is their life like? What's working for them? What's not working for them? What's a good day like? What's a not so good day like? What's important to them? Just a lot of the things that Dr. Flynn has been talking about as well. And so the way that a social work does that is by doing a comprehensive psychosocial assessment. And the way that we get our information is by having what we call goals of care discussions with an interdisciplinary team with our patients. And by doing that, we're able to ascertain a lot of information for the whole person. Not just their medical part, not just their psychosocial part, not just their spiritual part, but the whole picture. And I want to emphasize that our assessment is a continuous assessment. We look at the person's unique situation, their unique health status, and how that might be changing, because we know it probably is going to change if they're having any kind of diagnosis or disease process. We know that's going to change. So it's a continuous conversation. The other thing that palliative care does is they provide a continuity of care. And definitely for us, people tend to have transitions in their hospital course. So they may have a lot of different things happen during their hospitalization, and they may discharge. They may come back to the hospital. And when they come back, we jump back in again because we know the patient, we know the family, and we continue to provide that support for them. And that allows us to build relationships and keep getting to know them better and really digging in deep to find out what's going on for them so we can best support them. Another thing that's, as a social worker, that we provide is psychological support and counseling. And this is a big one because anybody going through any kind of illness has all kinds of different thoughts and feelings, especially if it's a new diagnosis or just a long-term diagnosis that they're trying to cope with. And I think one thing that a lot of our patients experience is what we call anticipatory grief and loss. And that's really what happens when a person is experience maybe a loss of functional ability, maybe a loss of cognition even, just kind of contemplating what their future is in the context of their disease process, and just kind of what they're feeling. We kind of help them sort that out. What are they feeling? And help them cope with that, find ways to cope with that. And another big one that we deal with a lot is caregiver stress, especially when patients come from the community and they have a family member caring for them. As their care needs change, we really try to hone in on how the caregiver is doing. That's as important because they're providing the care for the patient. So we really try to support them in that they're able to do some self-care, maybe have some respite care. Another thing that I personally spend a lot of time on is discussions of advance directives and healthcare powers of attorney, because we find that patients that come into the hospital, I would say, well, I'm going to throw a number out. I'd say like 5% might have a healthcare power of attorney filled out. And this can be very problematic if the person that the patient wants to be their surrogate decision maker in the event that they can't speak for themselves is not their legal next of kin. So we really try to get these things sorted out in the hospital, and I help them get those documents in order while they're in the hospital. And definitely advance directives, it's always good to have those in writing to guide the medical team should a person not be able to tell us what their wishes are. The other thing that a social worker does a lot of is provides resources and transitional planning. And by that, I mean, as things change, connecting patients and their families with resources in the community that will support them through their journey. And that might be a support group. It might be maybe a wellness program, counseling in the community, things like that that just really buff up their support. So that's kind of the nuts and bolts part of what a social worker does in the palliative care program.
So a chaplain on the spiritual care on the palliative care team is also referred to as a spiritual care provider. And the spiritual care provider on the team provides support for spiritual needs. And spiritual needs means identifying spiritual concerns, can also mean providing support for rituals. And by rituals, I mean things like it could be anything from breath work to readings or prayer, meditation, helping people connect with various communities. It could be faith communities, it could be different kinds of communities of support. We also help with emotional, spiritual, and existential distress. And when we think about existential distress, sometimes we think about asking questions of why me? Why is this happening to me? Why is God or the divine or spirit allowing this to happen to me? Or perhaps anger, sadness, or grief with respect to loss of faith, loss of a community or a community of faith. Spiritual care providers also provide support for people at the end of life or who are considering the end of life, maybe addressing questions and issues that are related to death and dying. We assist in these goals of care discussions that we're having as a team, and sometimes we provide support after the goals of care discussions, and this might be processing feelings about these discussions, and also assisting as those goals are changing, and facilitating communication between patients, loved ones, and the healthcare team. An important idea is distinguishing between spirituality and religion. Spirituality is a very broad concept, and it's actually very difficult to describe. It constitutes something which I consider the core of ourselves, but it also reflects the way that we live. Within the healthcare context, we think of spirituality as the way a person seeks and expresses or finds what we call meaning and purpose. The way someone connects to the transcendent, or what we call something greater than oneself, perhaps connecting to nature, art, or the significant or the sacred. And then when we think of religion, religion is a component of those things. And it may be a particular system of faith or worship. And a spiritual care provider is there to provide support for the continuum of spirituality, and that includes religion and religious expression. So spiritual care providers pay attention for certain key kinds of struggle that people with serious illness may be facing. And so this may be facing, people may be facing meaning, struggle with meaning in the face of suffering. So grief related to key relationships or illness or frailty, maybe struggling with feeling diminished because of a serious illness. People sometimes have struggles with a loss of integrity, or a sense of integrity, or a sense of legacy, wanting to have a sense of legacy. And this has to do with, are they feeling complete with tasks in life? Feeling distressed about living perhaps a life that doesn't feel perfect. Maybe having concerns about relationship, concerned about being a burden, or having feelings of isolation. Spiritual care providers are, as I mentioned earlier, listening for concerns about fears about death and dying. And these concerns can have to do with wanting to participate in important events before death, or being torn between wanting to let go of life or wanting to continue to fight on, having uncertainty about what may happen after death, or perhaps how the process of dying may go, being fear of having pain or pain in the dying process. Being willing to process these feelings with a spiritual care provider is not uncommon in the process of getting support with palliative care. There are also issues related to making decisions about treatment or specific religious and spiritual struggles.
Now, about talking about palliative care specifically in Parkinson's disease, like I've said a couple of times before, a lot of what I deal with is things like complex symptom management. Pain is a very common symptom for patients dealing with Parkinson's disease, whether it be a joint pain, neuropathic pain, all the different types of physical pain. Insomnia is a big thing in the sleep disorder category. Fatigue, poor appetite, nausea and vomiting. Especially in the nausea and vomiting field, we know some of the drugs typically given for persons for nausea and vomiting can actually make Parkinson's disease worse. So we have to keep that in mind when we're using the right medications in those classes. A lot of depression is seen in persons with Parkinson's disease, as well as constipation is a very common issue. A lot of these things we deal with both on the inpatient and outpatient side in the palliative care field with Parkinson's patients. And like I said before, a lot of our, I think, big part of our involvement in persons with Parkinson's disease is sitting down with patients and families, discussing kind of where they're at and what their illness and what their goals are ultimately. We help listen, talk to patients and families and help develop guidelines for the current care as well as the future care if their Parkinson's should progress. But I think a big part of what we do as the team is we sit down with patients and their families to listen to kind of what their values are, what their hopes are, what their fears are, and we take all that information we're hearing from them, and we help kind of process it in the light of diagnosis, what the prognosis is, and helping kind of hear what they want. And that informs us what may guide our future medical treatments going forward, as well as whatever resources may help support them as they go through this journey. And a lot of the issues that we encounter are what activities are most important to maintain an acceptable quality of life, and how the patient and the family will kind of like to navigate their ongoing care needs or the increasing levels of patient dependence on others for care. A lot of the questions we really talk about and ask patients and families is, how do you defend quality of life? Kind of what do you enjoy on a day-to-day basis or look forward to? What is the toughest part of this? And sometimes we get into, what are you afraid of as you go through this, as you look to the future, as you deal with this disease?
So in our experience in palliative care, and as clinicians, we've noticed that some of the challenges that individuals living with Parkinson's disease face include things like isolation and changes in family roles, loss of independence. We've noticed changes in self-identity, relationships dynamics, and also fears, like fears of losing love from primary caregivers, particularly if the primary caregivers are a spouse or significant others. And then there are spiritual issues that may accompany Parkinson's disease. And there are really many types of spiritual issues that can accompany Parkinson's disease. And some of them are religious and spiritual struggles. Some of these issues that I'm going to describe may be familiar, and some of them may not feel familiar at all. But I'm going to define them by category and just explain what I mean when I talk about religious and spiritual struggle. Some people experience what we call divine struggle. And by divine struggle, I mean, you can sort of fill in the word, what you mean when I say divine or divinity. It could be God, it could be the divine, it could be mystery, but something related to the transcendent. And it's a struggle with regard to that which we don't, which we think of as beyond ourselves, but some kind of divine struggle. Some people experience demonic struggle, perhaps struggle with regard to the devil, or wondering about demonic involvement in the disease process. Some people experience struggle with regard to doubt. Could be doubt related to faith, or it could be doubt related to things that don't have to do with faith, maybe self-doubt, for example. Moral struggles that aren't necessarily contained within a religious context, although they may be, but more of an internal one. Interpersonal struggles and struggles with ultimate meaning. And then another area of spiritual distress that comes up for people has to do with adaptive tasks. And these adaptive tasks also connect to the spiritual issues of meaning and purpose and relationship and transcendence. These can be establishing meaning and understanding the significance of the situations that come up with Parkinson's disease, and also confronting the realities and the changing realities that come, and responding to the requirements of the external situation, sustaining relationships with families and friends, particularly as isolation creeps in, maintaining reasonable emotional balance when upsetting feelings are aroused by the situation, and then preserving a satisfactory self-image and maintaining a sense of competence and mastery. This can happen by balancing both accepting help and then maintaining an active sense of control around identity. And then finally, thinking about spiritual care and how it helps in the setting of Parkinson's disease. One of the major things is considering how to strengthen the spiritual self. Strengthening studies have actually shown that in the setting of chronic illness, people have often scored higher on spiritual well-being inventories, and spiritual coping mechanisms are strengthened in part because of the need to turn inward, and perhaps feeling more connected to the sacred through ritual practice. And that ritual practice are the things I mentioned earlier that could be public or private practice, but also the search for meaning in a setting of perhaps some diminishment in life, but also an internal flourishing in life. Feeling more connected to others through the need to reach out. And then also perhaps a belief that there is some divine help that may be forthcoming. And again, some of these may feel resonant and some of them may not feel. But there also may be a refocus on the inner self. And that refocus on the inner self can come through at times through narrative storytelling. Narrative storytelling is a particularly helpful tool for spiritual care providers when, particularly in the inpatient hospital setting. It's something that we use frequently to help people kind of step out of the illness experience and share their stories. It's the use of past experience to express the current understanding of the present experience to contribute to future planning. And it's something that is an iterative process to continually reimagine a future reality. And so we encourage connection with loved ones and also creative expression.
So now I'm going to talk a little bit about specifically how social work looks with Parkinson's disease. And I first wanted to talk a little bit about some of the challenges that we face. And I think you'll find that some of what I say and some of what Lorraine has said are connected. I mean, they overlap a little bit because they are connected. And it's so I'll just refer back to some of the things that reiterate some of the things that she's already said. But I did want to bring up one of the biggest things that a social worker will look for in a person with Parkinson's disease is depression. We know that people with Parkinson's disease, they have a higher rate of depression than most of the general elderly population. And feelings of depression are not uncommon, and actually they're quite normal when a diagnosis of Parkinson's disease or any neurological disorder is given. So we know that both depression and anxiety are very prevalent and very much impact their quality of life. So much so that studies have found that depression and anxiety affect a patient and a caregiver's quality of life, often even more than physical impairment, such as the loss of motor skills in a Parkinson's patient. The difficulty is that it's difficult to diagnose Parkinson's or diagnose depression because Parkinson's can mask the symptoms of depression. And actually, we are very much aware that a person who is experiencing depression from Parkinson's, it's an emotional reaction that's actually a sign of healthy grieving from suffering from the disease. So some of the symptoms that come with Parkinson's disease that can mask the signs of depression are things such as poor concentration, sleep disturbances, decreased facial affect, weight loss, constipation, as Dr. Flynn was saying. These are prevalent to the extent that a skilled clinician might not be able to separate them and diagnose them separately. So we are keenly aware of this, and also the fact that there's other things that come along with suffering from the disease as the disease progresses, such as embarrassment, stigma, isolation, problems with self-esteem, self-image, and also a decreased amount of social activity and changes in relationship, as Lorraine was talking about, for both the patient and the caregiver. Next, please. So what can a social worker specifically do for a person with Parkinson's disease and their family? Well, the primary thing that we do, which is kind of the baseline for all of our work, is we collaborate interdisciplinary team for continuity in patient care. So again, as I talked about before, our psychosocial assessment, where we figure out the entire landscape of the person, what's working, what's not working, what are their stressors, their strengths, what are their supports in the community, where do we need some buffing up of supports. It's an all-inclusive picture. It's a holistic picture. And thinking holistically and working as a partner with patients and their families helps empower people and helps people maximize the resources that they do have available. So another thing that we do a lot of is supportive counseling. And supportive counseling can take the form of many different things. It can be one-on-one counseling. It can be support groups. And I'm a huge fan of support groups because that's a very safe place typically for a person with Parkinson's or a family member to share their experience of what they've been going through with others who most likely have been going through the same thing or something similar. And it helps them feel not alone in the journey. I mean, I think that's a big part of it, is that they don't feel like they're just out there, trying to navigate all of this on their own. They have other people who are doing the same thing and can support each other. The other thing that social workers can do on a more practical level, and this probably would apply more to the outpatient setting, is we can provide access to resources to encourage medication adherence. Because what studies have found is that oftentimes patients with Parkinson's maybe are seeing many different providers. They're seeing, they have different supports in the community. They're trying to navigate all of these things, and they're taking a lot of different medications. And so what a social worker can do is help them strategize how to keep all of that straight in terms of like starting a new medication. Is it working? Is it effectively treating the symptom? And what dosage are they taking? They can provide pill boxes. They can maybe help them, a person, keep a medical log of the medications they're taking that they can take to their doctor so that the doctor knows exactly what's going on. They can provide timers that help them remember when to take their medications. And basically just provide encouragement to the person with Parkinson's as a partner in healthcare, to encourage them to stick to their medical regimen so we know what's working and what's not. We can also help them address barriers to healthcare, I think is what I would call it, which is really things like lack of transportation. Maybe there's insurance issues or no insurance, financial stressors, maybe medical co-pays, things like that. We can help connect them with resources to solve some of these barriers. And really, I think, I said this before, but I'm going to say it again, the resources in transitional planning is a huge part of social work, because the one thing we know with Parkinson's disease is that it's going to progress. We don't know how quickly, we don't know exactly what the future is going to look like for that particular person, but we know that their care needs are going to change. That much we know. We know that for sure. So one of the things that we can do is help the person with Parkinson's plan for that in terms of caregiving, having the help they need to be as functional as possible and have the highest quality of life as possible. So we can help them with that, so that both the person with Parkinson's and the caregiver have what they need for maximum effectiveness. And I just want to call out this book, Counting on Kindness, The Dilemmas of Dependency by Wendy Lesbader. It's a great book, super insightful, that covers specifically what we're talking about when care needs change and a person becomes more dependent and some of the things that go along with that. It's a great read.
So I think, kind of to wrap it all up, I think, you may be asking, how can I access palliative care? Obviously, if you or your loved one find yourself in the hospital setting, you can always ask whatever your main hospital doctor is, is palliative care available here? Would we be able to be seen while we are here? If you're in the community, obviously you can ask your neurologist, primary care provider, or other specialists for a referral. And if none of those are really options, there's a really great website. It's called getpalliativecare.org. And if you see the picture there, there's a little, it says access the provider directory. You just click on that. You put in your address or your zip code, and it brings up whatever palliative care resources may be in your area, so you can possibly reach out to them and see if you could be seen and get involved, get palliative care involvement in your life. I think that's the best way to put it. So give the references, and I just want to thank, like I said, Jen and APDA again for inviting us. And any questions you have, we'd love to hopefully answer for you.
Well, hello, I am back, and there are some questions. So remember, folks, you can type your questions into the Q&A function. If you put it in the chat, I'll see it as well. So, and we do have a couple of questions. One thing that I'm going to clarify right now, I had someone ask for the name of the book and the author. I should have said this at the beginning, because if you were taking mad notes, I apologize for that, but we will share their presentation with you in the post-event email. So you will have access to that, so you can reference that book. It was called Counting on Kindness. So by a woman, I did not write it down. But you will have access to that. So, first question goes way back to the beginning. And how is palliative care really different from active care? And why is there a difference? I think you mentioned that at the very beginning, Dr. Flynn. Can you speak to that?
So, yeah, I'm not sure if I misspoke, but palliative care is not different from active care. And like I was saying, the difference between palliative care and hospice is for someone that may be enrolled in hospice, they can't be going through active care like chemotherapy or hemodialysis for kidney failure, while someone that's followed by either our team or the outpatient setting, they can be undergoing active treatment. That's the big difference. So, I have a whole panel of patients that are still going through chemotherapy. They're still on dialysis. They're still going active treatment for whatever the neurological disease is, but we're following along for that pain and symptom management, the support, those ongoing check-ins about how are you doing, how are you feeling with things, kind of what are you worried about as you go through this, and kind of how can we put it all in the big picture kind of thing. So we are not different from active treatment. Like I said, once someone does feel like they may not want to do treatment anymore, they can't do treatment anymore, and they're really getting close to the end of life, that's where hospice comes in and the active treatment part kind of falls off.
Okay, great. And speaking of hospice, how is spiritual care different in palliative care and in hospice?
That's an excellent question. Spiritual care, I would say spiritual care in the hospice setting and spiritual care in the palliative care setting is quite similar. I think in palliative care, spiritual care is really collaborating with the palliative care team and asking and questions and supporting the idea of this, as Dr. Flynn was saying, kind of active treatment alongside. I mean, the kinds of questions we might be asking would have to do with the philosophy of palliative care, whereas, but we would still be addressing maybe fears about death and dying that are resting right alongside the desire to pursue active treatment. Those two things can exist at the same time, and spiritual care a spiritual care provider would want to be present for any of those kinds of questions. And those kinds of questions may still exist when someone goes on hospice care. So I think in a way that the fluidity of care would look quite similar. The kinds of, whether it's ritual support or emotional support, spiritual support, reaching out to faith communities, those kinds of things are going to look quite similar. So yeah, I don't know if that quite answers the question, but.
Okay, great. Thank you.
Sure.
And this is kind of asking about hospice as well a little bit, but I think I understand this question. How do you determine when a patient meets the hospice requirement of less than 6 months time span, I think, versus the need for palliative care? How do you determine those two pieces? Does that make sense?
So that would be, that makes total sense. And we see that a lot. We get patients that may be undergoing active treatment, and they say, you know what, I'm thinking about not doing this anymore. Whatever it may be. I bring up chemotherapy a lot because that's probably the biggest part of things we deal with cancer patients. And basically the 6-month determination is made by a physician, basically saying, documenting more often than not, if you stop treatment, you'd have 6 months or less to live. Okay. And it's an ongoing, evaluation for patients. A lot of times we have patients that say, I think I'm ready for hospice. And then you say, well, it's like, well, actually you wouldn't qualify right now because, more often than not, you would actually live longer than the 6-month period. So it's based on a specific diagnosis that make you eligible, and then prognosis based on how long you may live if you aren't undergoing active treatment.
Okay, great. So 2 questions kind of about the doctor and qualifications. So one question was, is a doctor in palliative care a general practitioner or what? And then if you get palliative care, do you leave your regular doctor?
Okay. So I'll start with the second question first.
Okay.
No, you don't leave your normal doctor. I mean, we basically act as an extra layer of support. We coordinate with their primary care doctor, with the neurologist, whatever specialist they have. We help coordinate a lot of that care because I think the best way to describe kind of my role is I take all that information in, what the cardiologist is saying, what the oncologist is saying, what the neurologist is saying, because they all have that little piece of the body they're focused on. I help take all the information I'm hearing from them, looking at the big picture, distilling it down, and helping, present it to the patient in the light of their quality of life, I think is the best way to put it. So you're still seeing your primary care doctor, whatever specialist you're seeing, you're still seeing them. I just happen to be someone else coming in the picture to help with the symptom management. Sitting down, because I have the time to sit down for an hour or so, talk about what they're going through. And that, it takes a lot of time constraint off that. Maybe a general practitioner may only have 15 minutes, and you can't have really, kind of existential conversation in that amount of time unless you're very efficient. But, it's hard to do that. So you don't leave your primary care doctor. There is, and to address the question, is a doctor in palliative care a GP or what? My primary board is family medicine, but then I went on and did a fellowship to subspecialize in palliative care. So I was originally a family doctor. And there are different levels of palliative care. There's primary level palliative care, meaning general practitioners or hospitalists that are familiar with it. They can provide the basic palliative care, and then specialist level palliative care. For me, myself, I don't practice as a general practitioner anymore. I only do palliative care. So to answer the question, some GPs, some palliative care docs are GPs, some are just subspecialists in palliative care like myself.
Okay, great. And how long are visits typically with patients and families in an outpatient setting?
That's a good question. I think for at least our clinic, I think initial visits might be an hour, if I'm thinking off the top of my head. And I think follow-ups maybe a half hour. They're definitely longer than primary care visits. Just because, like I said, we have a lot more to assess. And I know at our clinic, typically those first visits are with one of our providers, whether it's a physician or a nurse practitioner, and the social workers. They really do that at the comprehensive palliative care assessment for what their needs may be. And then the follow-ups, obviously, they kind of focus on what's the important issues.
Great. And so it really sounds like, my whole understanding of palliative care is very much, it's a team approach. There's a lot of people that are involved in this. And so one of the questions is, in the palliative care team approach, can you receive support from just the spiritual care advisor?
Another good question. Generally speaking, as the spiritual care provider sees patients in the team consultation first, and then will follow up with patients individually. That's generally the model that we use in the inpatient setting. In the outpatient setting here at Swedish, I could see patients as a spiritual care provider as needed. So if there was a need in the clinic, I could be called out of the inpatient setting to see someone in the outpatient setting. And I might do that by phone. as a follow-up after an outpatient encounter.
Okay, great. Where do I want to go? How do I find a social worker?
How do you find a social worker? That's a
very good question that I get asked all the time.
I think it depends on where you are. If you're outpatient, if you're inpatient, I think the best way to find a social worker is if you are connected with a primary care clinic or any provider really, I think there's a lot of social workers in the community through different organizations. So it really just kind of depends on the situation. But I think the place to start, if you really want a social worker to support you and to help you get connected, I would start with your primary care provider and or any provider that you see on a regular basis that knows you, and let them know what you feel like you need the social worker for. And I think that they would be able to connect you. That's what I would say.
Yeah. And I would say many of the movement disorder clinics, particularly for Parkinson's, do have social workers on staff. And if they don't, they can call places like us and we can try to connect you, or, try to figure that one out. So,
and I think more and more, we see, especially geriatric clinics, will have a social worker embedded in the team, in the actual clinic, just like movement disorder would. It's a great idea. I think they should all do it, but no, not everyone does. So that would be my advice.
Okay, great. Question about the Counting on Kindness book. Is it a best read for the patient or the caregiver?
I really say both. It's kind of what I would call a more simple read in terms of it's not just a gigantic, voluminous book. It's, I think it would be good for both, honestly, I do. Because I think for the patient, it would identify probably things that they're feeling that they don't realize that other people might be feeling as well, or that might be very common for people to feel in their situation. And I definitely think for caregivers, because I think for them, it would be helpful, I think, to understand what the person is going through that they're caring for. It might help in their relationship and just how they are with each other. Just, like we've talked about, changes in relationships. I think it would give them some insight to that. So I would say both.
A book club for two people to read together. Yes.
Yep.
And I have to go back to the social worker question. Barbara wrote in the comment that she has a social worker from her medical insurance company who works as a case manager and has been a really great resource for that. So perhaps worth an ask to your insurance company as well. So speaking of insurance, there are a couple questions related to how does one pay for medical care? Is it covered by Medicare? Are there limitations to most insurance plans? What's the technical stuff with that?
I'm not sure if Joan wants to field that or Joan wants me to field it.
Go ahead, Chris. I'm going to let you do it, as I always do.
It's covered by Medicare. As far as the different insurance companies, obviously they'd have to reach out to the insurance companies. As we know, every insurance company does what they do, so I can't really speak to that. But Medicare does cover palliative care, both on the inpatient and outpatient side. I know that much. As far as the other piece, maybe Joan knows. I'm not sure.
Every insurance is so different. I'm sure that I can't imagine that they wouldn't cover it. But again, I think you just, as a subspecialty, I think you just have to reach out to them and find out what their coverage is. Sure.
So there was a pretty specific question in the Q&A about a specific situation. I'm not going to go through the whole thing, but essentially someone's been living with Parkinson's for quite a while and has a lot of discomfort and pain and is quite miserable often and unable to do a lot of things. The question was any suggestions that would help him. And I would generalize that a little bit. Would that be a great situation for palliative care? Can you talk towards that?
Yeah, definitely. I mean, yeah, as we were talking about, the symptoms that go along with Parkinson's disease are very debilitating for patients, for people and their family, the loved ones walking alongside them. In this situation, obviously, I always say to people, just be very open and honest with your provider, whether it's your neurologist, your primary care doctor, and don't be afraid to say, hey, I don't think this is working. Is there something else we can try? Can we try a different dosage of whatever medication? Can we try a different medication? Can you refer us to palliative care? And a lot of the patients we get involved with are referrals because of these symptoms that the neurologist, the oncologist, whoever don't feel like they're adequately managing the patient's symptoms, and they want kind of like independent party to look at the picture, and that's a lot where we come in. So I think being very honest and don't be afraid to speak up with your neurologist, whoever, and then saying, hey, I think we could probably use another set of eyes looking on this. Would it be possible to get a referral to palliative care? Like I said, whether it's on the inpatient, outpatient, wherever.
Mm-hmm. Okay. And this is a little bit related. We have 2 more questions here. So Anne commented that she would hope that all clinicians would have these palliative care characteristics, especially with Parkinson's. Why do you think this has come out as a separate specialty?
I think a couple of different things. As you can imagine, if you've dealt with a lot of different specialists in medicine, they all have different personalities as far as why a certain personality goes to a certain specialty. And the other part of it is time. Like I was saying, you need to kind of want to do it because it is hard work. You're dealing with a lot of very sick patients and very distressed families. And I think you need to want to do that and be passionate about it. I think every provider should have at least some of that primary palliative care I was talking about to know how to facilitate those basic discussions, have the basic pain and symptom management skills. But as we know, a lot of neurologists, a lot of primary care doctors don't have the time to really sit down and go through these things with patients and families. And I think to be honest, personally, a big part of it is personality, kind of what they can really, what their view is on the world, on medicine, on people, and how that manifests, and what type of physician they end up becoming. So I think that's the best way to put it.
Okay. Questions keep popping in. So I'm just going to take a couple more because we are running out of time and I want to respect your time and respect the audience's time. So this gentleman says, I'm my wife's caregiver. She has several chronic conditions. What is a good reference for a caregiver to understand information for all the medications and interactions? Where would you send this person?
I mean, typically someone's primary care provider should be the one coordinating all their care and trying their best to work with the other specialists to try to minimize what we call polypharmacy, which is all these different medicines. That would be my first place to start. I would really kind of not advise going on the internet and just trying to look up all the different medications and side effects, because you will drive yourself crazy. I mean, you need someone with that the medical knowledge to really distill down and like I said, limit the polypharmacy and speak with the specialist and say, hey, we're on these 2 medicines that are kind of similar from 2 different doctors. Do we really need both? Or what can we stop one, limit one, things like that? Because, we recognize that, someone that's on 20 different medicines, that's hard to take that much medicine every day. And it's hard for people to kind of keep track of things.
Mm-hmm. And I've heard Dr. Kamani at Swedish talk about like polypharma, like there's a place at Swedish where he sends folks to talk about all the medications. Is that think that's what I've heard him say. Is that correct? From your awareness, there's like a polypharma coordination sort of thing, or am I making that up?
I'm not sure about on the outpatient side. No, I know on the inpatient side that the pharmacist a lot of times will chime in and say, "Hey, these two medicines interact. We should probably think about starting that." Or it all depends. On the outpatient side, to be honest, I'm not very familiar with
Okay.
that.
Yeah. And then as far as there's a question here about sort of Medicare covered situation, and also related to how does palliative care integrate with home health care? Like getting home health involved.
Yeah, I mean, home health is, I think Joe can speak to that, it's a little separate from what palliative care does. Like I said, in some communities, there's the palliative care community-based resources that can come out to the home or at least follow up via phone. I know our clinic right now is doing, since COVID started, they've been doing a lot of like Zoom interactions with patients and families. So it's actually helped because a lot of patients that live not in Seattle, but live maybe out in the peninsula or some rural area that can't make it into Seattle, are able to at least be followed by our outpatient team. Joan, I don't know if you can speak to the home health itself.
So home health, I mean, it's a separate entity. So it's covered under the Medicare benefit or whatever insurance you may have. It's fairly common. We send a lot of people go home on home health that are being seen by palliative care. So I think the only thing would be, I think anytime you have more than one provider that they're coordinating with each other, I think that's always really important. But home health is going to be very specific about nursing needs, physical therapy, occupational therapy, that type of thing. Whereas palliative care is going to be more kind of the big picture, where are we going with this type of thing.
Okay. And then we did have a question about, and you alluded to this a little bit, Dr. Flynn, is how has the COVID pandemic impacted your ability to interact with the patients and the family during this journey? And it sounds like you've transitioned a little bit to the virtual world, but can you talk a little bit about how your work has been impacted by that?
Yeah, I think all three of us could speak to that because the gold standard for our initial interaction with the patient and family is we're all there, the entire team. It's not just me going to see a patient, then people follow up. And it's been really hard. Obviously we like to meet patients and families face to face. And it's been a lot of speakerphone, a lot of FaceTime, things like that. And it's not the same, especially if a patient is in the hospital is critically ill and their family can come and see them, especially if it is a COVID patient and they can't come and see their loved one. It's been really hard. Obviously, being at the bedside with the patient and their family talking about these things, I think it's a lot more therapeutic. And it's great to meet with people face to face. I mean, via phone it's not the same thing. It's been really hard on patients and their families, to be very honest, that they can't come in and be there with their loved one when they're sick. It's been a tragedy to say the least. So
yeah, for sure.
And I would add to that. At the same time, we've gotten very creative. We have iPads and Google phones, and we've learned to use every app under the sun. To connect with other people using every app under the sun to be able to bring people together in the ways that we can. So we really have been able to make connections in the ways that it's possible without actually being able to have people in person. And so while it has been incredibly difficult, and I echo everything that Dr. Flynn has been saying about it not being ideal, we've figured out how to make the best of it using the technology that we've been given. And so, it's kind of as good as it can get.
Thank goodness for technology, because I can relate to this. We wouldn't be doing this, with such a wide audience of people from all over the country are on this call, or at least signed up for it. So Yeah, so that's been beneficial, but we do miss people in person, and there is that therapeutic standpoint that you talked about for sure. So
Absolutely.
yeah. So we are going to wrap up this program today. Like I said, we are going to send out the slides to you in the post-event email. We will post this on YouTube probably next week. You'll get all of this stuff. And our next Take Control, I'm going to ask for parting words from our panelists in just a second, but I just want to let you know about our next Take Control is going to be on November 19th, and it is called Brains and Brawn. So it's combining cognitive training and exercise. So we're going to welcome back Dr. Nate Coomer, who's one of our favorite physical therapists in the Seattle Parkinson's world. And he's going to talk about making the link of those connections between the brain and the body. So he will be here in November, so you'll get more information about that. So I really hope this has been valuable for those of you who are on the call. I've certainly learned a lot from our panelists. So thank you very, very much to all three of you for sharing your knowledge and this topic. Any last parting words that you want to say to our audience or about palliative care? Any words of advice, anything like that?
I'd probably say thanks again for inviting us. It means a lot to us to help share kind of our specialty and how it can impact the lives of people dealing with Parkinson's disease as well as their family members. And like I said, if you feel like that palliative care is right for you, talk to your primary care provider, whatever other specialist for referral, or you can go to that website at the end of the presentation. And like I said, it can be provided alongside your primary care or your neurologist. You don't need to stop seeing them. But we're here as an extra layer of support, both for physical things as well as emotional, spiritual, the whole person. I think is the best way to put it. So thanks again. We appreciate it.
Yeah, thank you. Anything from either of you ladies?
Just really grateful to have the opportunity to spend the time with all of you today. And it's really, really a pleasure to be a part of this.
Yeah.
Thank you so much. Thank you. And at Palliative Care, we just want to make sure that you're not walking the journey alone. We want to walk it by your side.
The perfect parting thing, because that we believe that as well here at APDA, that there's an amazing community out here and no one with Parkinson's should ever feel like they're by themselves.